If you look into the timeline of ACL, you'll see that we started long ago in 1903 with the ACL repair. Then it has gone through various modification changes. And probably in 2007, we were almost settling down with the single bundle anatomic transportal ACL reconstruction. We thought that that is the benchmark of ACL reconstruction. And of late, 2000 from 2016, 17, people started doing a remnant preservation, and they say that this is more biological and more anatomic. But if you look into return to sports, this is a paper 2021 from OJSM, a systematic review which says that the return to sports ranges between somewhere between 40% to 90%. So in some cases, it is 40%, in some cases, it is 90%. So the question is, even with the state-of-the-art technology that we all are using at this moment, why not all patients are returning to the sports? There are lots of, hypothesis and opinion coming up, but my personal opinion, and many people, they say that probably we are neglecting the concomitant injuries. We are not properly treating the concomitant injuries. So these concomitant injury could be a MCL injury, lateral collateral ligament, ram tear, root tear, cartilage, and so on and so forth. So many more we still don't know. So probably those concomitant injury that we already know has to be taken care of. I'll show some of our example. This was one example of MCL, and before that, a prelude is MCL injury is a game changer, we all know. But if you go to literature, they are graded into grade 1 to 3, and they suggest that grade 1 and grade 2 can be treated non-operatively, whereas grade 3 has to be treated operative. If grade 3 is isolated, probably that can also be treated non-operatively. So if you follow this chart, the treatment looks straightforward and very simple. But can this be used for all of our patients? Of course not. If you see these pictures, which are some of our patients where the femoral side avulsion of the MCL, there is a tibial side avulsion of the MCL, which is known as Steiner's lesion. Sometimes the avulsion from proximal side and incarcerated into the joint. If you can see that arrow shows all those things. These are the cases where there is no role of conservative treatment. These all require surgical operations. This was one of a very learning case for us. This was a 23-year-old lady. She was a professional footballer, a national player, came to us with an isolated MCL injury. If you can see that this was just a grade 2 opening. Just a grade 2 opening. When we saw her MRI, so this is MRI in which you can see that this was completely a grade 3 injury. So we thought that since grade 3 injury can be treated operatively, we suggested actually to undergo surgery for her, but she refused. She was not willing to go for surgery. And when she came to us after 6 weeks, you could see that the MCL has beautifully and completely healed. So we thought that probably most of the MCL injury can be treated conservatively. And immediately after that, after some time, this was another patient, a 24-year male, again a national footballer. So he came to us and we saw that in this case, there was a little bit more opening than the previous one. But if you see the MRI of the same gentleman, you see that this was just grade 2 tear, and that is how it has been reported by the radiologist. So since this was a grade 2 tear, we thought that grade 3 we managed conservatively, so this can also be managed conservatively. So what the patient comes to us again after 8 weeks, and you see that he demonstrates this valgus stress test himself. So the conclusion of this thing is, if you compare both the one, so clinical findings and MRI findings, they do not match. So do not depend upon MRI findings to treat your patient. Probably clinical judgment is more important than MRI. And we all know that MCL is most common concomitant injury along with ACL. There will be dilemma addressing MCL at the time of ACL reconstruction. So rather than radiological indications, a clinical examination, preferably under anesthesia, is the best judge for the treatment of medial collateral ligament. Counsel the patient accordingly. So you counsel the patient saying that we may need to reconstruct your MCL. I will examine you under anesthesia while undergoing your ACL reconstruction. Then we'll decide. If MCL injury is missed at the time of ACL reconstruction, the outcome is fourfold poorer than the ACL is addressed. So MCL is a very important factor and a very important game changer. Coming to the lateral collateral ligament, again the same thing, grade 1 and grade 2 can be treated non-operative. Grade 3 has to be treated operatively. Again, the treatment looks simple and straightforward, but there are so many other variables. We all know that MRI is lesser sensitive for the lateral side injury. The clinical examination is more complicated than the medial side injury. Probably dial test, which not all the surgeons they use, is again very important to understand. So we all know that the lateral side is called as a dark side of the knee because MRI sensitivity is extremely low for the posterolateral side. The clinical examination is complex. Interpretation of the findings, interpretation of the dial test itself is a controversial. That is why most of the surgeons, they try to ignore the lateral collateral ligament. I'll tell you one story of one of our patients who he was a club player in National Football League. 18 months ago, he underwent football injury and underwent ACL reconstruction with hamstring graft. Then after 6 months, that means 12 months down the line after the surgery, he returned to practice. And during the practice, he said that it was not exactly the injury, it was a simple twist. And then he started complaining of giving way and he was not able to play. So when he came to us, this was the X-ray he came with, and then we did a scanogram of that particular patient. You could see that there is a lateral opening of the knee joint because we do all X-ray on a standing. So there was a lateral opening, there was a lateral injury. We did a scanogram to see the axis, either there is an axis deviation or not, but his axis was almost within the normal limit. This was his clinical examination. I'll go into that. This is a Lachman test, post-operative 18 months. It was positive. So ACL has completely failed. The anterior drawer test was positive. And in interest of time, I'll not show you. His varus stress test was also positive. This was his MRI in which you can very clearly see that the ACL has completely failed. There was a bucket handle tear, which is now added to his initial injury. And there was a proximal avulsion of the lateral collateral ligament. So the surgeon has ignored his lateral side injury while doing his primary ACL reconstruction. Then we had to revise his ACL. We all know that the outcome of revision of ACL for the elite sportsman is not as good as the one. So we revised with BPTB and did a posterolateral reconstruction. So the summary of this case is missed LCL is one of the commonest cause of primary ACL failure. So whenever we treat ACL, we must think about what is the status of the lateral side. MRI is poorly sensitive to PCL injury. So do not read MRI. Decide based upon your clinical acumen. Stress radiography, which very rarely people do, probably that is stress radiography. We all have Shyam. Take the patient under the Shyam and do a proper examination to identify the posterolateral coronary injury. Probably that is the way to go. Coming to the third game changer, it's a ramp lesion. Probably we can say that this is new kid in the block. So say about 3 years ago, nobody knew about ramp tear, although it was reported by Sonri Kote and Thanot long ago, but ramp tear was not detected. So relatively, this is newer member of concomitant injury, but as you go along nowadays, in last month only out of 15 cases we did, 5 cases had ramp lesion. So it is that frequent. Once you start identifying it, you will find out more and more ramp lesion. The problem with the ramp lesion, this is also called as a hidden lesion. So it is not visualized from anterior scopy that we regularly do to identify meniscus. So you have to go to the posteromedial compartment. There are various maneuvers that will modified Gilchrist maneuver that will allow you to go into the posteromedial compartment. And the needle examination is key for the identification of ramp tear. This is one of our latest video. If you see that this patient had a torn ACL, which was known from MRI, his MRI reported to be normal. So when we scoped from anterior and doing a probing of the meniscus looked perfectly okay, except if you appreciate, regularly do, there is a more of an anterior laxity or anterior movement of this meniscus. If you don't know how much movement it has to be, you can very easily miss. Then I did a modified Gilchrist maneuver and went into the posteromedial compartment. If you go into the posteromedial compartment, you find out this is a very subtle type of injury. You see that tear looks like nothing. You can just miss it or you can just ignore it. But what is important, as Sonri Cote, they say that needle examination is very, very important of any suspicious lesion. So when I passed my needle, I thought that this is not only a simple tear. So what I did, I made a posteromedial portal. So posteromedial portal, making posteromedial portal is very essential acumen for all the arthroscopy surgeon. And you pass your probe from the posteromedial portal and try to inspect and examine this ramp lesion, you'll find out that this was not a simple lesion, but this was a complete ramp tear. And ramp tear is neglected. They can result in, if these tears are neglected, they can result in early failure of your reconstructed ACL. So again, ramp tear is a game changer. That is why diagnostic arthroscopy of all ACL tear must do a posteromedial examination, and the ramp should be revealed. So it is a hidden lesion. Sometimes you may not see it. That is why you have to reveal the ramp lesion. Coming to my last one, game changer, that is a root tear. Root tear, we started understanding this root tear very, very lately, probably 5 years ago. My seniors and colleagues are here. 5 years back, we were not able to identify, and we were not taking this root tear very seriously. So what is root? It has two, every meniscus has two roots. So most commonly termed roots are posterior root. What happens if there is a tear of the posterior root? So the anchoring is not there. So what happens gradually when the patient weight bears, your meniscus starts extruding out and it gets fixed outside the joint. And then there is an excessive amount of force concentrated into the bone, which will lead to the severe osteoarthritis or accelerated osteoarthritis. If you go to MRI and try to read by yourself, you'll find out that these features, these three features, the ghost sign, the meniscus extrusion, and the truncation sign are very regularly present in case of this kind of root tear. I'll not go into detail of that, but again, if this research comes from Europe, where they say that lateral meniscus posterior root tear are very often missed, now you can imagine what is the situation in our context. So our radiologist, sorry to say, will be not telling you that the patient is having a lateral root tear. So you have to identify by yourself, read your MRI by yourself. So our retrospective analysis of about 260 ACL tear, we found that the sensitivity of root tear as a whole, for meniscus as a whole, was only 60%. If you go into the lateral side only, it is below 30%. Believe me, my friends, below 30% of the lateral root tear are diagnosed by our radiologists. So these are very often missed. So in scenario of poor MRI sensitivity in our country, we have to be extra vigilant to detect these injuries. And root repair is very important to reestablish the normal biomechanics of the knee. It doesn't need any emphasis, we all know. If you miss root repair, osteoarthritis is inevitable. And we all know that meniscus has a stability role. So if your stability is also less, the chance, more stress on the ACL, and the chances of failure of ACL is very, very high. This was a very interesting case. I don't have his full detail because I was not able to collect those. This patient underwent an ACL reconstruction about a year ago, but he was never relieved of pain. On this side, you'll see that there is a decreased joint space on the medial side. So when we retrospectively looked into his MRI, we found that the medial meniscus root tear was missed. That was the cause of his accelerated degeneration. So we did a high tibial osteotomy on this patient, and he is 2 years down the line for the follow-up, and the patient is doing well. Probably if we could have detected his root tear then and repaired the root along with ACL, the patient wouldn't have required this amount of metal in his tibia. So to conclude my presentation, I would say that there was an era when we were happy with just an ACL reconstruction, wow, the ACL garyo damal bhayo bhanda. Now we have understood that only good ACL reconstruction alone is not enough. Concomitant injury have to be identified and addressed adequately if you want to get a good result out of your ACL reconstruction. So concomitant injury are the game changer in treatment of ACL reconstruction. Thank you very much.